to all the dignitaries and all the esteemed panelists today on this panel. We have a lot of esteemed doctors and physicians on the panel today. I'll start with Dr. Ijaz Ilmi sitting next to me. Of course, today we're talking about some blind spots in CSR and where are the issues that are frequently overlooked, Dr. Ilmi. So, in fact, I got a chance to just say hi to him before the panel and came to know that he also practices functional medicine, which is very heartwarming to know. So with that in point, and considering that handling cardiometabolic diseases and progressive chronic diseases in modern medicine is limited to pharmaceutical intervention, what is your take on how integrative functional medicine or more bioregulatory medicine can be used at a larger platform, and also think of using it in a CSR platform?
Thanks so much for giving me this opportunity. Well, I'm Dr. Ijaz Ilmi, and I practice consulting physician, and I practice functional medicine, which is the future of medicine is functional medicine, because the pharmaceutical industry is probably growing at 5% every year, but the disease is climbing. Chronic diseases like type 2 diabetes, hypertension, fatty liver, Alzheimer's, dementia, and PCOD for adolescent girls, these are climbing at over 10% every year. So obviously the doctors are doing their best, but they need help. How do you mitigate this pandemic, the second pandemic? We've had COVID, the new pandemic is the pandemic of chronic metabolic diseases, which affects everybody, and now we see adolescent children as old as 15 years, 18 years, coming to you with fatty livers because of ultra-processed foods. And they're diabetic and pre-diabetic, and half of these cases are not diagnosed because nobody wants to go and test. But then it's only when they start putting on mammoth amounts of weight, then the parents get concerned and they get a basic blood biomarker test done. And then you get to know that the child is not suffering from one, but maybe multiple metabolic chronic disorders, which were largely preventable in the first stage. So with the pharma industry rising, with the number of hospitals going up, with the number of gyms going up, but the disease is far ahead of that. So one has to think out of the box. You have to reimagine, rethink, reset yourself, and also think of what else is the cause which is leading to metabolic disorders. I always say this to people, and I quote my favorite professor, it's Robert Lustig. He says most chronic metabolic diseases are not druggable, but they are foodable. So nutritional intervention in terms of identifying the deficits which cause disease, and also how do you use nutrition interventions to actually allow your body, which has the real magic. I don't believe in magical foods. I believe that body has enough magic in itself. You can get it to a chronic metabolic dysfunction level. It will cause 5 years, 10 years, 15 years, and disease will creep up to you slowly. But the body inherently has the capability to reverse, stall, and maybe get into remission with all these chronic diseases if you allow the body, the inherent magic in its body to function. So this primarily is what nutritional medicine is all about, and we try our best. And I believe that we are actually aiding the doctors because who are largely overworked. And I might sound a bit controversial in saying this, but a lot of doctors are so overworked that they don't have time, and the patients actually feel let down when you don't get more than 5 or 7 minutes with the doctor. But the doctor, if you're charging money, it's imperative on you to actually make the people understand science. It's a shared responsibility. Your disease, the patient has to take it upon himself that it's my responsibility also. I can't just leave it to the doctor alone. Unless you share this responsibility that I need to get well, because if I'm the provider, my family needs to get well. My children are in the prime age of college, getting jobs, probably marriage, so I need to stay healthy. So my children should not say to me that when our best time came, when you're getting jobs and getting married, I had to tend to my ailing parents who probably suffering from hypertension, type 2 diabetes, liver disease, chronic kidney disease. So this responsibility can only happen if the doctor and the patient have this shared responsibility among themselves to fight this menace of this epidemic of chronic metabolic disease. Simple blood biomarkers, I'm going to be brief. Simple blood biomarkers, just getting your blood pressure checked occasionally. And also, one of the most important things, what you can do at home, is just take a measuring tape or a thread if you don't have one. If your height is say 5 feet 6 inches, and that's 66 inches, and if your waist is more than 33 inches, 50% of your height, then you definitely have visceral fat, and your propensity and your chances of heading towards metabolic disorders is very, very high. Simple few blood tests like liver function test, kidney function test, HbA1c will give your doctor a complete idea that you are not in optimal health, but your biomarkers are suboptimal. When I did my medicine, my physiology and pathology, this is like 40 years ago in Bangalore University. The biomarkers for an important enzyme like SGOTP used to be 0 to 25. Now the same parameters when you go to get your blood tested is 0 to 50. But any doctor of functional medicine will, after 30, 35 SGPT, they will understand that something is going wrong, insulin resistance probably happening, and there's bile buildup and your liver's under pressure. So obviously, the industry is such and the mechanics are such that healthcare is obviously such an important thing of our lives, but the rising cost of healthcare is leaving everybody under pressure. So it's better to that prevention and understanding your own body, thinking about yourself, thinking about your family. These are the key things that I want to talk about. Thank you so much.
Thank you, Dr. Ijaz. And as you correctly said, functional medicine or integrative medicine, as we call it, is the medicine of the future. What you're really trying to say here is that we always talk about prevention. We talk about the fact that most of these non-communicable chronic metabolic diseases are preventable. You can prevent them from happening if you know what is it that you can do on a daily basis, whether it's your food, sleep cycle, stress levels, movement, activity, everything has a role to play. And if you know how to do this well, you can prevent it. But there's another part to this also in functional medicine, which is not just limited to preventing metabolic diseases, but also looking at metabolic diseases in the sense of remission, in sense of looking at them in a format where you don't have to live with it. So God forbid if I get diabetes or high cholesterols or fatty liver and so on and so forth, I don't really need to necessarily live with these diseases. And there is an opportunity that medicine already knows about to put these into remission, to get this out of the way. And that's huge, considering that as a nation, we are crippled with the burdens of non-communicable diseases. And to extend it to community and to the larger group and to people who may not be able to afford treatment, I think is also extremely important. So thank you for your inputs, Dr. Ijaz. I'll take the next question to Dr. Ratna. And Dr. Ratna, thank you for joining in. We've also had a session on maternal health early in the day. And looking beyond maternal health, what are the other chronic diseases that you think are, also a bigger part of women's healthcare problems that are not normally looked at? With women, we tend to limit ourselves to maternal health and menstrual hygiene and reproductive health itself.
Thank you, Dr. Manjari, and good afternoon, everyone. I'm Dr. Ratna. I'm actually a public health physician, but the hat that I'm wearing today is to represent the patient voice. I run an organization called Dakshama Health, which has a coalition of about 80 to 100 patient organizations. These are organizations that are run by patients or caregivers. And I was just hearing Dr. Ijaz talking about shared responsibility. So our motto, and this is not something that's in India, it's a global motto which says nothing about us without us. There is a WHO framework document which says meaningful involvement of people living with non-communicable diseases, where patient is considered an expert in his or her own condition and can bring as much value to the table as any scientist, medical professional, or any other person who works in healthcare. So on this premise, we work with patient groups to understand what their perspectives are and bring their thought processes to the table to not only shape policy, but also treatment protocols. And we know that most of medicine comes from the West. So does it really work for populations in the context of our country? And if it does not, what is it that we need to change? So this is a little bit of the work that I do. To answer Dr. Manjari's question, we generally talk about maternal health or health in the context of reproductive health. But then women are always at a disadvantage as far as healthcare is concerned, because A, they are not the financial decision makers in the family. and B, they do not have, sometimes they do not have the ability to go to a healthcare center. So there is a geographical access issue, because they do not have the transport, or they are not able to make it to a healthcare center. So conditions that are beyond metabolic diseases, like say endometriosis, 1 in 10 women suffers from endometriosis. 30% of women with endometriosis suffer from infertility, very stigmatized, huge taboo, nobody wants to discuss. And combined with that is severe intolerable pain that makes the person so disabled that they are not able to function as a normal human being. Similarly, PCOD, heart failure, stroke in women. And then another thing that we normally do not discuss is mental health in women. Most women think themselves as very, very resilient, and therefore that topic is not discussed. But we as a patient group or a patient representative organization feel that all health should have mental health. There should be no health without mental health, and I'm sure Dr. Desai will agree with me on that. And we've seen this. We have patients who have been discharged from the hospital after a stroke, come back home, refuse to eat, refuse to follow the instructions of the caregiver, and deteriorate, have a second attack of stroke, and are back in the hospital. Why? Because nobody thought that they need counseling. The caregivers need counseling. There is so much of burnout in caregivers for chronic long-term conditions. Nobody ever talks about mental health issues for caregivers, especially for children. If it's a spouse, at least they have the patience and the ability to be able to take care. But children are stressed out because they have to take care of old parents or people with disability in the house, and there is no institutional support mechanism to be able to take care of mental health for these people who have long-term chronic conditions. So I would think that there are a lot of gaps because we are talking of blind spots in CSR. CSR does not traditionally look at these areas, and I think it's time we invested in these areas. Thank you.
Completely agree with you, Dr. Ratna. And because you mentioned mental health, who better than Dr. Desai to talk about this? So Dr. Desai, I'd like to, although we could go on and on talking to you about mental health, but I have a set of specific questions targeted at you. So, for mental health and lifestyle disorders in particular, as Dr. Ratna also mentioned, there is not much talk of it or intervention or even reach of these in the community when we look at CSR initiatives or any other form of community initiative. So, where do you think the government, the policy maker, where are we going wrong? Why is it limited to only larger hospitals? And why are we not reaching the community?
Thanks so much, Dr. Manjari. You're right. If I heard you correctly, I have what is a common sign in psychiatry, racing of thoughts. बहुत सारे विचार आ रहे हैं दिमाग में और आपके सामने कौन से रखूं कौन से नहीं रखूं ये नहीं पता. But I'll try and share a few quick ones. About 98 years ago, Aldous Huxley published a book called The Brave New World. And he said something, he described the whole medical science, health scenario, society. And he said something very beautifully, which today is so much more true. Aldous Huxley said in 1932, now medicine has advanced so much that hardly anyone is healthy. Now we have come much farther on that route because of our sensitivity, the technology improving, the diagnosis getting better. So there is virtually not just in psychiatry. Now I want to come to the closer point, but I'll come to that in a minute. Not just in psychiatry that we all can be diseased or abnormal or unhealthy, but even in physical health that's actually true. The second point that I want to make, linked to what Dr. Manjari and Dr. Ratna are saying, I don't know if it has been discussed since the morning or how many of you have realized. The paradigm shift from communicable diseases to NCDs in the Western world and for Afro-Asia, dual burden of disease, came up not because of WHO alone. Health organizations alone would have shouted from rooftops from 200 years and nobody would have listened. Guess who joined? The World Bank. It was the World Bank WHO project started in 1990, began to publish data in 96, 99, 2000 and after that brought out the whole issue of how NCDs are important. Everything that Dr. Ratna was saying, that NCDs still remain a blind spot. In spite of all this, somewhere, yes, in Afro-Asia, I guess understandably, to empathize with the government, I am now a free bird, not in service at all, so no reason for me to defend. But to be fair, the bureaucrats, the policymakers, the groups, working groups have a problem because we are going through a dual burden of disease. You know? So how that is where the CSR can step in. But the SR has, in fact, much larger blind spot. If I might use the terms, and no offense to the other gender or the other two genders, but CSR does not find mental health or NCDs very seductive or sexy to work with. It's not. You know, I mean, you work with HIV, you work with a whole lot of other topics. I might slightly differ with whoever one of these colleagues said that the issues of NCD became important in terms of behavior. No, actually, if nothing else, this pandemic recently taught us that all health is related to behavior. One, all health is related to collective behavior. It's not even my health will depend on how I behave or my lifestyle, but how we all collectively behave. Now that's important. That's where the prevention promotion part that my colleagues have been talking about will come in. Curative, rehabilitative medicine or healthcare is essentially one-on-one, individual. You the patient, I the doctor, or I the health provider. The moment you come to preventive and promotive paradigms in public health, it has to become mass-based. And that is very difficult for people to do. I found it very interesting. Dr. Aijaz made some great points. A lot of them are moving towards functional medicine, and a lot of psychiatry is moving from being called functional to organic. A lot of psychiatrists don't like, what was called as functional disorders, the disease of the mind. We all want to identify with the brain. But my one or two last points before I close for this part is this. Actually, it's a serious problem that 50 years ago, with all respect to all who must have been big shots then, Pandav Sahib will know firsthand, the 1974 definition of health is a serious problem. And we in mental health are very thrilled about the fact that it includes in the latter part physical, mental, social health. So be it. My problem is with the stem. Health is not only absence of disease, but a positive state of well-being. Damn it, and here again, I think I differ with Dr. Manjali. If I understood her correctly, you don't have to live with the disease. I think you have to live with disease. Good health or optimal health, that Dr. Aijaz said, I love that term, optimal health, is learning to live with disease, impairment, disability. Is there anyone in this hall who can say that he or she, however your age, even 25, 30-year-olds, certainly those who are over 40 or 45 years old, you have never had a health problem, you don't have an ongoing health problem? No one. If you in fact add up the prevalence rates of all the, we say 15%, Nilesh shared freelance, somebody will say we are 20%, we are 15%, the total goes up to more than 200%. So if you include comorbidities, physical and mental health both, living with the disease is the idea of health. I really sincerely want to put this to you. And 50 years down the road, sir, 74 to now, 2024, it's time to review and revise the definition of health. The last part in that line is that mental health, obviously, no, I leave mental health alone. I want to go back to what Dr. Ratna said. Lived in experience or subjective experience or the consumer experience, call it what you want. If there is one trend that is unarguable in last few decades, is what Dr. Ratna emphasized. Doctor alone, technical expertise alone is not enough. Now, what CSR initiatives will be able to examine that together? Does healthcare service delivery, does health outcome, does optimal health get better if you have a participatory approach as compared to I doctor, you patient? That I doctor, you patient ideas are decades old. So CSR really needs to focus on even that, really.
Yeah, thank you. We'll take it later, please. Okay, thank you, Dr. Desai. That was, as you can see, everybody really listened very earnestly. Thank you for those points. We can still debate on whether we can be free of disease or live with disease, but maybe later at some point of time. I'll take the next question to Dr. Anuradha. Dr. Anuradha, how is it possible that we develop enough successful strategies? And when I say strategies, I'm saying post the COVID pandemic, we were able to do something, with the pandemic. How can we replicate successful strategies to meet the public health challenge that we see today, considering that we're talking about blind spots in CSR today?
Good afternoon, everyone. I'm Dr. Anuradha Kernar, and I'm the chairperson of W Shakti Foundation and Director Healthcare in ISAP India Foundation. Thanks, Manjari, for giving this opportunity. The COVID-19 pandemic was, we all know, it was, one of the biggest pandemics in the entire human history. And we are very proud that India is at the forefront of handling this crisis situation, not only internally, and we also helped the other countries as well. During this pandemic, the way the disease was handled, the crisis was handled by the government and by all the stakeholders was really commendable. And we could take a lot of lessons from our handling of this situation into other healthcare areas. And this is happening. Actually, this is being recognized that there are a lot of successful strategies that could be adopted in handling the public health challenges. I would start with the first thing, the power of collaboration. This was the first time, I think, the entire force of government machinery, corporate partners, and people like the NGO partners and even the community, every single part of the community came together and pulled this big cart and to achieve the success in handling the situation, whether it was the disease burden or even the vaccination. So the power of collaboration was clearly demonstrated during the COVID pandemic, and we could all see that how we all come together and to handle public health challenges like TB, diabetes and mental health and all the the challenges that are still remaining. And number two, convergence. Even amongst the stakeholders, we were a part of COVID vaccination drive. So even the stakeholders, the multi-stakeholders that are in the community, whether it's the NGO partners, whether it is the faith-based organizations, MSME agencies, you could, women self-help groups. So any organization or anybody in the community thought that they had to play a role in in handling the situation and improving the vaccination drive. So we could all see that I would say everybody was able to see the greater good for the society. So everybody played their role in handling this. For example, in a very remote part of Bengal, we were doing a vaccination. Even those village boys, they became the peer champions, and they could go and bring all the old people in their own vehicles, and even carrying this vaccinators to travel 10 kilometers matlab pahad chad karke without chappals they could travel and then give the vaccination. So it was really heartwarming to see that if the community could see that the collective effort could result in a greater good to the society. I think that was demonstrated during this COVID pandemic crisis. And the third thing I would say is the community engagement. Like previously I mentioned, the community also played a very great role assessing that everybody was doing for their benefit. So that was a great thing. And finally, I would talk about the technological adoption. The COVID was the first ever, I think, technology adoption on such a large scale, which I think none of the other countries were even able to replicate. Whereas even in US, they were getting handwritten certificates. We in India were able to download it on our mobile. We had it at our fingertips. And that has been replicated now to UWIN, for the routine immunization of the children. So likewise, there are a lot of technology adoption that has happened at a micro level and at a macro level, and are being replicated to handle the public health challenges. So these are the couple of successful strategies we could look at a granular detail, and how they worked and why they became so successful. That could be replicated in handling other public health challenges. Thank you.
Yeah, thank you, Dr. Anuradha. Of course, there are a lot of takeaways from COVID, but now COVID is behind us and we have newer challenges to meet. Obviously, some of the strategies and things that we learned in COVID can be adapted. One of them is, of course, technology, as you mentioned. I mean, all of us in India had our vaccines on our phones, and we could track them, which was quite a remarkable thing considering the population and the length and breadth of this country. So yeah, I think these are things that can be adopted. If you're looking at reaching the community, we'll take the next panelist, Ms. Garima now. Ms. Garima, how do you think, in which areas specifically would you think there is a need in CSR for more funding and more support to come through?
I'm from IPAS Development Foundation, and we work for preventing and managing unwanted pregnancies, which includes abortions and contraceptions. And we also work with young people, youth and adolescents in parts of the country. So we work with Government of India, we work with private sector. Foxy is one of our leading partner. We collaborate with them, and we also work with CSR organizations. So coming to the question and the topic you asked, Dr. Manjari, I think CSR plays a very vital role when it comes to augmenting government strategies that they are implementing. We all know government has its limitations. We as CSR partners or CSR organizations can augment the government services by collaborating and taking the services to the last mile. I think where CSR can fund more is what Dr. Desai briefly touched upon is on behavior change communications. Generally what happens is that CSR fundings are short duration. There are various laws that govern that, but the fundings are short duration. The activities and the targets are very time bound. There are limited resources. However, if we want to see change, we need to work on behavior change, especially for the youth that is coming up, and they are contributing. They are going to be the largest workforce that that India is going to create now. If you see our demographic, if you see the population, if you see our what do you call that? Pyramid, yes, thank you so much. The population pyramid, the youth forms the biggest chunk of that pyramid, and they are going to come into the workforce soon. So I think that we can, and CSR can collaborate together, organizations like us can collaborate together with CSRs to take up the behavior change for sexual reproductive health to the community.
Yeah, thank you. That I think, Garima, I agree with you. And obviously, there's a lot of scope in terms of funding, in terms of support in the community in CSR. So let's have our last panelist, Dr. Vibhor Avasthi. Dr. Vibhor, my question to you would be about the advocacy, really, and healthcare advocacy. The more we do this, still it's very less on ground. There's a lot of advocacy channels. The government itself is trying to do a lot of advocacy around health, both preventive and treatable, and of course maternal health and many other things. But how do we make advocacy stronger, and how is it that advocacy can play a major role in ensuring that the CSR activities actually see the light of the day?
So thank you so much, Manjari. First of all, thank you to the organizers. I actually was feeling a deja vu, that feeling like a backbencher, where the question always comes to last. The only difference is in college we used to be happy that there's no question to be asked, but I'm glad you are asked a different question. See, I'll start by saying that in our own health setup, and I'm not talking about CSR right now, there is a lot of siloization of what we are doing. Now, for example, we just had a talk, a panel discussion before this, and there the psychiatrist was talking about dementia, schizophrenia, Alzheimer's. What we have felt is that there is a lot more of mental health apart from that, and I think Dr. Rizvi has already spoken about this before. In fact, our organization, which is the Organization for Comorbidities, is basically talking about the presence of more than one disease in an individual, which in India is very, very common right now. So what we see now here is that a physician treats hypertension, the physician treats diabetes, maybe also a kidney disease followed by diabetes, but nobody is willing to know what the mental status of that person is. Now, what I also have seen in different forums is, and I have been part of the psychiatry conference, which is ANSIPS, and other conferences also. ANSIPS is the only conference which is now talking about psychiatric illness in comorbidities. If you go to any of the diabetes conferences, cardiology conferences, they very rarely talk about the presence of these diseases. So I think that is number one problem, and I think the same thing might also be coming in the CSR activities. So what I feel is that the CSR activities are operating in silo, and what we need to do is we need to connect them together. So one silo has to connect to the other silo to give the proper advocacy to the government and make some kind of a policy. Unless that happens, I think that advocacy part would actually not come very well. And one of the example which was given was adult immunization. Adult immunization has been worked very well. It's a very great CSR initiative, and now the government of India is actually accepting a schedule of adult immunization, as a routine for every physician to follow. The second thing which I wanted to say is we have to make sure that all the activities, or at least the message of the activities, needs to go to the grassroots. I still feel we are working too much in the 25-30% of the Indian industry. I think what all good things are happening should go to the grassroots level, go to the villages, to the primary health care, and this will only happen if the CSR in some way connects with the government of India. And I think the HEAL Foundation can be a good kind of a string which can bring them together. Thank you.
Thank you, Dr. Vibhor. Thank you so much. So, one of the things that you pointed about, mental health, and about the fact that there are psychiatric conditions in people with comorbid conditions. In India, as you correctly said, you don't have a person just having one ailment. There are multiple comorbidities, and obviously it not only leads to psychological stress, eventually it leads to psychiatric conditions. And one of the things that that is not addressed is mental health. I mean, to take a very simple example, in chronic diseases like cancer, where trauma and mental health is a big thing that needs to be addressed, there's still very little that we do about it, and we mostly focus on the therapy part of it, the pharmaceutical intervention part of it. So yes, I think that's very important. Also, all of us see it in our clinical practice on a daily basis, the number of people who look for support, for psychological support, for therapists is tremendous. There is so much of requirement and ask for it, but solutions still are not enough. So yes, and that's one thing. Also, another thing about mental health, because we tend to, put mental health and physical health in two different brackets, and we tend to sort of disassociate each other, whereas the truth is that, in terms of your bioregulatory systems, in terms of physiology or a pathophysiology, the origin of both is the same, and both are interconnected to each other. So whether we're looking at the psychosomatic influence, whether you're looking at micronutrient deficiencies, whether you're looking at gut inflammation or systemic inflammation, all of it is leading to both forms of conditions. So I think it's very important for not only healthcare providers, but everybody in healthcare setup and regulatory bodies and everybody else in the landscape to recognize that a person who's going through any form of physical condition or a clinical problem also has associated trauma and mental health conditions, and they have to be simultaneously addressed, and
I'll just have one point. I forgot in the deja vu. Sorry. I think what we are forgetting right now is family. I think family support should be one of the biggest CSR activities we're looking at. So you might be talking about any disease. A patient suffers, but I think the family also suffers along with it. And there are very few CSR activities which are revolving around, taking care of the family. So I think that is a part which is important.
Yeah, I'd like to finish this. I'd like Dr. Desai to add something on the family bit that Dr. Avasthi mentioned.
Right. I agree. I agree with Dr. Vibhor completely, and Dr. Ratna and I do, I think, too. There is amongst a whole lot of pluses and minuses of different countries and cultures, what Afro-Asia, as I keep referring to, and South Asia in particular, has a huge strength is however worse off we are in terms of family systems as compared to 40 or 50 years ago, we are still a lot better than a whole lot of other countries. And so we need to capitalize on not just curative health and rehabilitative health, but preventive and promotive health at the level of family. But that reminds me of something, if Dr. Andrada doesn't mind my picking on that one idea. And it's a concern, it's a challenge as I see. I also see hopefully we will do it. What she described so well about how we handle the epidemic beautifully, I have only one concern. See, most of us or all of us will remember the great Indian wedding. Till last minute, everything is a mess. In that last few hours, everything falls into place. So we are very good in crisis management. And we did that in the epidemic. I am not too sure. My concern is how much we will be able to sustain that on an enduring basis for health systems. That's my concern. But the other thing occurred to me as Vibhor was saying, I'm not one of those 5-star NGO or physician guys, as you might realize. But the buzzword, if it has not come up since the morning, is intersectionality. Some years ago we used to talk about intersectoral approach. Then it changed to intersectionality. Whatever be the not so hidden cynicism about newer terms, but yes, intersectionality makes sense, especially in the light of what people have said. Physical and mental health comorbidity, if I might again Manjari pick on one of the things that you said, not just between physical and mental health. My mom in Ahmedabad at 90 has had huge orthopedic problems, 3 TKR operations, fracture shaft femur. She also has serious GI problems, serious respiratory issues. So forget mental and physical health overlap, but within physical health itself, a whole lot of issues overlap, and the person or the unit functions as one. Unfortunately, the idea of joint management, even in clinical medicine, is kind of disappeared already. And there, I have only one more concern that I think I wanted to pick on. I want to continue from what Dr. Adna said. Thanks, sorry. The whole issue about women and mental health, as she said, seriously, but in a lighter vein, about 60 years ago, early 60s, British researchers found that in UK, British Isles and all over the world, as far as they could study, depression was 2 or 3 times more common in women as compared to men. Okay, good epidemiological data, not just hospital data. But men, if you are chuckling, don't. Because to me, that's only an indication of the biological hormonal issues and the exploitation that men have done of the other gender for wrong. And so, will health issues or the gender differences in health issues will also be subject to socio-economic political change. Now, that's a delicate issue. How is CSR ever going to fund that and work with the government? I have no idea. That's a challenge. Can we pick up sensitive issues and work on them?
Thank you all for being a great audience. Thank you to the participants and the panelists.